discuss death and the possibility of dying, it should come as no surprise that families often have a limited, if any, idea about what level of medical care their loved one would want as their condition worsens in the ICU. Advanced directives and advanced care planning reflect the level of care desired by a patient when faced with severe, possibly fatal illness. Unfortunately, few patients have given much thought to these issues before admission to the ICU. Yet when available, these directives can be very helpful for guiding care at the end of life, when the type of care that can be provided can range from aggressive, invasive therapies to measures intended to provide only comfort.
These are issues that we're all going to face. We're all going to grow old. We're all going to get ill and die at some point, and that it's very important that we talk to the people who are important to us about the kind of care we would want if we got too sick to speak for ourselves, and about the kind of care that our loved ones would want if they became too sick to speak for themselves.
I think it's essential for anyone who can anticipate death, and that comes at different ages to people, but certainly most adults can anticipate death, to give thought to what they're going to do in the event of a critical illness, especially considering that a critical illness such as trauma may come out of the blue. It's easier for people with chronic diseases, but everyone should think about this because everyone could be traumatized in a society such as ours.
It's difficult to plan for serious illness that occurs suddenly. But what one can think about is what is an acceptable functional state? What is an acceptable quality of life for me? And how will the decisions be made if I am seriously ill? Who is going to make them? And what are going to be the operating principles that they use to make them?
One of the opportunities that we have when we are able to talk about the issue of end-of-life care is that gives us the opportunity to do some advanced planning, to have conversations in families about what preferences people would have about their care at the end of life.
Living wills do not solve the problem of what kind of care you want at the end of life. Living wills are a single piece of paper or a single document that tend to be very general and don't help physicians and family members make specific decisions in specific scenarios. I think it's far more important than signing a piece of paper called a living will is having the conversation with your loved ones and with your physicians about the kind of care you would want if you got too sick to speak for yourselves.
The most important thing that one can do in advanced planning is, number one, to identify someone who can speak for you if you are too ill or impaired to speak for yourself. This has to be someone who knows what kind of person you are and how you feel about medical care and about the quality of your life and what is acceptable to you in terms of a health state and a functional state. So the most important aspects of advanced planning in my mind are the identification of a decision maker, a proxy, to help speak for you if you can't speak for yourself, and then communication with that person about your own preferences and thoughts about quality of life and acceptable health.
Even when faced with a mild illness, like the common cold, many of us feel isolated and alienated from the people around us. Consider how much this must be magnified and exaggerated for the person who is dying and their loved ones. At a time when nurturing and human kindness is most needed, genuine communication between caregivers and patients as well as families motivated by compassion is often lacking or inadequate. This can only serve to heighten the feelings of loneliness and isolation that is so common to the dying process. What can be done about this unfortunate situation?
I think the public needs to be much more active in sharing their preferences with healthcare professionals. I think that every American ought to expect that their pain and symptoms are going to be treated appropriately. I think that every person ought to expect that their healthcare professionals are going to listen to them and engage them in trying to create a plan that will honor their values and preferences. And if we have family members who are aware of those options, then I think we can really begin to have the kind of dialogue that we need that will promote the very best care for everyone at the end of their lives.
I think the most important thing for public to ask of clinicians during end-of-life care is good communication, is keeping the family up to date, current about what's going on, making sure that the family understands the prognosis and the treatments that are being used, and when decisions are made to withdraw life-sustaining treatments, making sure the family understands what's going to be done to ensure the patient's comfort in the final stages of their life.
I think that the public should expect that their wishes about end-of-life care should be heard by clinicians and should be respected by clinicians. I think the public should be expected to be actively involved and to be able to communicate with clinicians about what their needs and their loved ones' needs are and if their needs are being met. I think communication among these people is absolutely essential and will provide, good communication will provide comfort to the family members.
As we have already said, talking about death is very difficult, not only for patients and their loved ones, but for ICU clinicians as well. As a patient or family member, how do we ask for help? When we need more information or when we want more support, what can we do?
End-of-life discussion should be initiated by anyone, and in particular, one party, the patient or the physician, shouldn't wait for the other person to bring it up because they may never get to it at all.
If you ask patients who should initiate these discussions, they say physicians should. If you ask physicians, usually they say the patient should. In my opinion, I think it's very important that both sides be initiating this discussion. When patients or family members feel like they'd like to talk about these issues, they should feel comfortable bringing it up to their physicians. In some of the research we've done, we've had patients tell us that they're uncomfortable bringing it up to their physician because they don't want to hurt their physician's feelings. And I'll tell you that it doesn't hurt physicians' feelings to talk about end-of-life care. I think it's an important thing to bring up.
Ideally, end-of-life discussions would be occurring in people's homes between patients, their family members, among family members, with family physicians in their offices before people become seriously ill. Too often in the intensive care unit, for the first time we're embarking on these discussions.
But if we lose the opportunity to have these discussions among the family members and providers, then we may be caught up short at the end and not be giving the family members the time that is needed to resolve some of the issues within the family.
So it is almost always appropriate to initiate some kind of discussion about prognosis and about appropriate and realistic goals of care. And that should be done by physicians, but it's certainly an appropriate area for a family to initiate if they have questions or concerns.
When confronted with critical illness, some of us may eventually face the agonizing and devastating decision about whether or not to withhold or withdraw life-sustaining therapies for our loved ones. Nothing can make this decision easy, but there are ways to ease the enormous burden we all feel when faced with this terrible question. In critical and chronic disease, thinking about these inevitabilities can only serve to help ease this decision-making later on. Doing all we can for loved ones may not always mean continuing aggressive care. In fact, it may be quite the opposite.